This is a video explainer for Medway Safeguarding Children Partnerships Local Child Safeguarding Practice Review called Nate. Welcome and thank you for setting aside time for this presentation. My name is Kirsty King and I'm one of the Medway Safeguarding Children Partnerships Practice Development Leads and also author of this report. I'll be taking you through this presentation. The presentation will include a short explanation of what a Local Child Safeguarding Practice Review is, the circumstances that led to this local child safeguarding practice review, the findings, good practice and recommendations from the review. The full report and a briefing can be found on the MSCP website. The link is on the screen. Before we start, please be aware that this presentation includes details of the death of a child. Please take care of yourself as the content may trigger feelings and emotions for you personally and professionally. You can stop the presentation at any time and come back to it when you feel ready. Before you start, make sure you have someone that you can get in touch with if you need support. This might be your line manager, a designated safeguarding lead, a colleague or a friend. Many employees have some form of wellbeing offer or service and you might want to check in with this. On the slide are details of organisations who can provide support. Working Together to Safeguard Children 2026 sets out certain responsibilities for the statutory safeguarding partners when a child dies or is seriously harmed and abuse or neglect is known or suspected. Here in Medway, the statutory safeguarding partners are Medway Council, Kent Police and NHS Kent and Medway. These responsibilities include commissioning local child safeguarding practice reviews. The purpose of a Local Child Safeguarding Practice Review, or LCSPR, is for agencies and individuals to learn lessons to improve the way in which they work, both individually and collectively, to safeguard and promote the welfare of children. They are often completed by independent reviewers or those not connected to the services involved. The reviews are not an inquiry into how a child died or was seriously harmed or into who is culpable. These are matters for coroners and criminal courts to determine as appropriate. A Local Child Safeguarding Practice Review is about the child, their experiences and our learning, and most importantly the action we take as professionals individually and collectively as a result of this learning. This Local Child Safeguarding Practice Review, or LCSPR, was commissioned in 2025 by the Medway Safeguarding Children's Partnership after the sad death of a 4-week-old baby, who we refer to in the report as Nate. The LCSPR was to consider practice and systems in working with children and their families where there are concerns about neglect, decision-making in pregnancy, supporting parents of children with complex needs and disabilities, and safety messages for parents caring for a newborn. The medical cause of Nate's death is septic shock with multi-organ failure secondary to invasive group A streptococcus infection. The conclusion of the inquest is that the death was due to natural causes. In 2014, father was arrested, charged and imprisoned for the attempted rape on an adult female. He is registered as a sex offender indefinitely. Subsequently, when he told his offender manager that his partner was pregnant in 2022, Kent Police made a referral to Children's Services. A pre-birth assessment was initiated and a strategy meeting held, which at review determined the case should be managed under a single agency Section 47 investigation. During the assessment, mother was identified as homeless and sofa surfing. The case was escalated to pre-proceedings but stepped down following positive parenting assessments of mother and a psychiatric assessment of father. The child remains subject to a child protection plan under the category of neglect. Following an early birth, the child was mostly in hospital until he was 7 months old. The child has complex health needs requiring daily physiotherapy, specialist feeding and regular hospital and other health appointments. Mother was diagnosed with postnatal depression and prescribed medication. During this period, there were times when the parents did not reside together, and for a period of time, father was not to have unsupervised contact with the child. The child remained subject to a child protection plan until April 2024, when the plan was ended and intervention continued under Section 17 Safeguarding Child in Need Plan. Mother booked her pregnancy with Nate in June 2024, shortly before the Child in Need Plan ended. At the final Child in Need meeting, it was recorded that mother was pregnant, but there were no concerns for the family, who reported they felt confident and had family support. There were no concerns for the care the elder child was receiving, and no pre-birth assessment took place. A number of health services continued to provide care and support for the eldest child and his parents throughout mother's pregnancy, and the family were frequently seen in appointments. Mother received her antenatal care under the midwifery vulnerability pathway. Nate was born via planned caesarean at 37 plus 1 weeks. Fetal growth restriction had been diagnosed the previous week and he was in breech position. Nate continued to receive care under the midwifery and health visiting vulnerability pathways due to the family history. Nate experienced weight loss after birth and so received regular visits from midwifery to monitor it. He was also seen in hospital by the infant feeding team. On the day of Nate's collapse, the midwife was visiting to discharge mother and baby from their care. Nate had gained weight and the parents were acting on the feeding advice they'd been given. Ahead of the visit that day, mother reported to the midwife via text that Nate was not feeding. On attendance, the midwife found Nate in a poor condition and commenced CPR. He was taken to hospital where he later died. Mother reported after Nate's death that he had had an ear infection and that the parents had taken his temperature, which was low. Whilst the offender manager was part of the multi-agency processes and did share father's risk assessment, consideration should have been given to the impact that working with a sex offender has on practice and decision making. Working with any perpetrator of violence, including domestic abuse and sexual abuse, is likely to evoke a response in professionals that needs to be considered and reflected on in decision making and engagement. There is a potential for an anxiety-driven response which results in accelerated decision making without time for robust risk assessments. It appears decision-making was reactive to father being a sex offender without full exploration of the risk. As part of the child protection plan initially, father was not to have unsupervised contact with the elder child. The risk posed by father and to whom he posed the risk at this time lacked clarity. Father was then permitted unsupervised contact with the eldest child from quite early in the process because the decision to restrict access was based on his sex offence and not the parenting assessment and his ability to meet the child's needs. There is little evidence for the justification for the lack of contact imposed on father, and practice appears to be risk-averse to the detriment of family life, with no analysis on what impact this may have had on the family. The rationale for then allowing unsupervised contact is not clear. Father's offending risk was low, and child contact does not fit into his offending profile. Professionals' understanding of what low risk means is not established. Outside of the child protection conferences and later the child in need meetings, it is not clear how the risks, safety plans around father's contact or general whereabouts of the father were considered or shared between the multi-agency partners. There is limited evidence of how father's sex offender status was understood or perceived as relevant and integrated into planning. Professionals such as speech and language therapists or dietitians were not part of the multi-agency protection processes, and so it's unclear how these professionals were updated on safety plans. In this case, the decision to go to Legal Gateway came before the initial Child Protection Conference, or ICPC. Whilst the decision is ultimately for social care, there is opportunity for the multi-agency conferences to explore the need for legal advice and establish an agreed evidence base for meeting legal thresholds. Professionals need to be informed on what the processes are to be able to inform and question decision making and feel empowered to ask questions about it. The initial rationale for escalation of the case to go to Legal Gateway before the ICPC took place is not well evidenced, as the child and family assessment did not address the current risk to the unborn. Risk alone does not meet the legal threshold unless it is both probable and significant. Continuing pre-proceedings despite no emerging concerns raises questions about proportionality, ethical practice, and child-centred decision-making. Mother's assessment was positive, suggesting earlier, more comprehensive assessment may have avoided escalation to pre-proceedings. Mother advised her midwife that her family was open to social care when she booked her pregnancy with Nate. She advised that she was open to social care with her eldest child being supported by a child in need plan. And Mother did not believe that an assessment was being completed on the unborn, and she had been informed that the child in need plan was in the process of being closed. The midwife confirmed this with the social worker, who reported there were no current concerns and the plan was to close at the next child in need review meeting. Mother was to remain on the midwifery vulnerability pathway, known as Team Connect. The midwifery records do not indicate whether there was consideration of a pre-birth assessment in line with the pre-birth procedures, or for seeking permission to request a child and family assessment from Children's Services. This case indicates that whilst there is appropriate contact with social care on open cases, if there is no intention to discuss the newborn at multi-agency meetings, then midwifery will not attend. However, the expectation from Medway Foundation Trust is that midwives should attend if the family are open. And if the unborn is not being added to a plan, then a separate referral to Children's Services should be made for consideration, and this is in line with the existing pre-birth pathway. The midwife was not invited and did not request to attend the final child in need meeting. It is important that all professionals working with a family attend these meetings to understand family context, what is being offered to the family, and the implications and impact these may have on the unborn's needs. Without a full picture of the family and their ongoing needs, the multi-agency practitioners do not follow the principle of think family. A better understanding of the family and consideration of issues that may impact on parenting capacity to meet the baby's needs would have informed their consideration of the need for a pre-birth assessment. With midwifery, health visiting and other health representatives missing from the final child in need meeting, there was no challenge to the pre-birth procedures not being followed. There should have been a meaningful multi-agency discussion regarding the need for assessment. Whilst the decision may have remained not to complete an assessment, this indicates a missed opportunity to consider the needs of the unborn. The offender manager, who attended the child in need meetings where mother's pregnancy with Nate was announced, had recollected that the second pregnancy was acknowledged but not discussed or commented on in terms of potential increased risk. They reported that there was no recognition that the impending birth of a second child into a family with a very young child with significant healthcare needs and parents with a history of mental health struggles may require further assessment. The reviewers considered that the offender manager was unlikely to have been aware of the pre-birth assessment pathway and so unable to reference the need for proper consideration for a pre-birth assessment. It is unusual for Kent Police to attend child in need meetings, and the attendee was not a child protection specialist. However, the review considered that professionals attending multi-agency meetings should be equipped with a basic knowledge of procedures and pathways that are applicable to the families. Records do not indicate that services considered the impact of father's mental health on parenting after the child protection processes. Whilst father's mental health needs were known about across services and noted in their files, these were not referred back to. Father did attend his mental health annual review in 2024, 6 months late, and his child and unborn are recorded, but there is no analysis as to the impact of his mental health, which was asymptomatic at the time. Whilst we can see from records that the mental health of parents was not seen as a risk at the time, there is a lack of consideration as to what factors, such as stress, could increase that risk. There is no consideration of the impact of parents not managing their mental health appropriately. The family appropriately received support from health visiting and midwifery via their vulnerability pathways due to the recognition of the parents' vulnerabilities. This meant they received continuity of care from professionals and increased numbers of contacts. Due to the concerns about Nate's weight loss, he was actually seen by health professionals 14 times in 4 weeks, 10 times by midwifery. Safer sleeping messages are well documented throughout the case with reference to thermoregulation, the focus being on clothing, bedding and feeling baby's body for changes in temperature and not necessarily related to temperature when a child is unwell. Mother reported at police interview that she had taken Nate's temperature on the day that he died and it was 34.6 degrees. Practitioners who was consulted as part of this review shared that they do not provide advice to parents on body temperatures and don't advocate for parents to take the temperature of a baby. This is due to the high chance of error as parents are not trained to take the temperature and the right thermometer may not be used or placed correctly. Baby's ears may be too small to get an accurate reading. The distress that the taking of the temperature causes the baby may cause the baby to move during the reading, and if a child has an ear infection, it would give a false reading. Instead, parents are told to check body temperature of babies using a hand to the skin of baby's chest and back. However, the professionals reflected that had mother shared the temperature reading that she'd reported to the police, they would have known that this was a dangerous temperature and asked the parent to repeat the reading and acted from there. Whilst Nate was mother's second baby, she had not cared for her first child outside of hospital settings until he was 7 months old. Practitioners reflected that in cases where there has been a child with very high needs, parents should be supported in responding to babies with lower needs, as they may have a distorted view of a typical presentation, and this would impact their response. The review found signs of sepsis should be explicitly referenced to parents and recorded stringently, as we do with safer sleeping. Although there is a risk of overload of information for parents, a child-focused sepsis message would support professionals and parents to recognise signs sooner. Although recognising the signs of infection and sepsis in newborn babies and those with complex health needs may be similar, they can be quite varied and sometimes difficult to identify. Nate lost 8.9% of his birth weight within 5 days of his birth. His weight was closely monitored and appropriate contact was made to the infant feeding team when his weight dropped to 11.3% below birth weight and then on to the paediatric registrar. The infant feeding team was consulted after Nate gained weight to inquire if a paediatric appointment was still needed to assess him. Professionals at a practitioner event reported that following his weight gain, there was no need for the paediatric assessment appointment, and so mother and baby were not required to attend it. They also shared that whilst Nate's weight was flagged by the feeding team to the paediatric registrar, he was on the borderline of concern, and in trusts outside of Medway would have been unlikely to have met a threshold of concern. National guidance suggests that professionals' responses to weight loss in the first few days after birth is triggered at a weight loss of more than 10% of birth weight. At the time that the appointment was cancelled, 4 days before Nate's collapse, Nate was 1.65% below his birth weight. Whilst Nate's weight gains had not been consistent, professionals reported that parents were acting on the advice given by professionals. Practitioners reported that parents took Nate's weight concerns seriously and followed professional advice. The feeding regime for Nate was intense, and mother had been able to introduce breastfeeding after initiating with formula feeding. This episode showed good practice in response to baby weight loss. The family appropriately received support from health visiting and midwifery via their vulnerability pathways due to the recognition of parental vulnerabilities, even without being open to children's services for Nate during the pregnancy or post-birth. This meant that the family received continuity in care from some professionals and increased numbers of contact. The family experienced support from some of the same workers in both pregnancies and following the children's births. This enabled the practitioners who participated in this review to reflect on the family and how they functioned. During the period of Children's Services involvement for the older sibling, the offender manager from Kent Police remained as part of the multi-agency response, including the Child in Need plan. It is important that professional network utilise offender managers to understand the risk posed by the offender's triggers, and the impact that may have on practice. The report makes 12 recommendations for the Medway Safeguarding Children's Partnership and individual agencies. The recommendations are set out in full in the report and in the briefing, and they will be taken forward by the Strengthening Professional Practice subgroup of the Safeguarding Partnership. Here are some generalised points for you to consider and reflect on from the recommendations. How well are you able to or supported in joining multi-agency processes? The MSCP will be looking at engagement levels across these processes. If you are working with a family you know to be open to children's services, what does your role in the multi-agency plan look like? If you are not invited to meetings, are you seeking an invitation? If you are supporting a family with an unborn, then you should be attending multi-agency meetings that concern the family. Do you know what the Kent and Medway pre-birth procedures look like, or what a good pre-birth assessment should include? All professionals involved in multi-agency processes should be aware of the local policy and procedures, and this would support them in challenging each other when they are not followed. It doesn't matter if your day-to-day role would not usually include direct work with unborns and babies. Nationally, it's recognised that working with men is sometimes challenging for professionals, and the MSCP will soon be publishing practice guidance to support professionals in this. In this case, father was often not recorded on file, not asked after, and his role in the family not understood. Working with offenders can create further challenge. In this case, professionals did not know enough about fathers offending and did not reach out to those who could support their understanding. So in your practice, how do you ensure fathers or important men in the children's lives are included in your work? The wider family were active in the support of this family and later in caring for the elder child. Where there are children with high levels of needs, all caregivers should receive the appropriate safety messages and training. The wider family network must be explored when they are being relied on to keep children healthy and safe. The review identified there had been little exploration of this family's history, which may impact on the ability of the family to actually support. It is also important to consider what a parent's experience of parenting has been. Do you include the wider family support in your contact with the family, or do you understand their role and their experiences? Parents receive a wealth of information in a short space of time during and after pregnancy. The signs of infection and risk of sepsis in children is a wider public concern, and the warning signs should be familiar to all parents, not just those with newborns. Are you aware of the signs of sepsis in newborns and infants? Could you support a family by sharing messages about childhood illness? Are your safety messages consistent with those given by colleagues in your service and from other services? How do you record the messages that you have spoken to the family about? Reflective supervision is important for reviewing professionals' engagement with children and families, but also in evaluating the effectiveness of the multi-agency working. Effective supervision may have supported and empowered professionals to challenge decisions or ask for rationale in this case. It may have also supported professionals to identify that father's input was missing from contacts and what the reasons for that were, which would include consideration on the impact of working with a sex offender. Whilst not recognised as concern at the time, throughout the case there were opportunities for multi-agency partners to question or challenge procedural compliance, communication and professional oversight. Consider the level of support you may be receiving or giving in management positions, as well as the quality of that contact and opportunities to analyse the impact and effectiveness of the multi-agency work. The practitioner event also raised a very important challenge. They reflected that the communication to all agencies following the death of Nate was not good. Professionals involved with the family were either not aware of the post-mortem findings or were not aware in a timely way. This is important for those professionals in helping them process and reflect on their involvement with the family. They were unaware of the child death review process and had not been part of it. The MSCP and the Child Death Review team will be reintroducing training on the child death process and the roles professionals play in it. Thank you for listening to this presentation. If it has raised some difficult feelings or emotions for you, please get in touch with your line manager, a designated safeguarding lead, a colleague or a friend. A reminder of the organisations that provide support are on the screen. There are many ways that you can keep in touch with the Medway Safeguarding Children's Partnership. You can receive the bi-monthly bulletin by using the email address on the screen to request a copy, or check out our website and follow us on our social media channels.